Great, Robin. Thanks for having me. I appreciate it. The bottom line is, guys, this is my first global pandemic. And as many emails as I've been checking, I have not been able to get a playbook on how we're supposed to be treating our patients. So we're really flying by the seat of our pants here, trying to decide the safety of our staff, the safety of our patients, but yet also provide effective treatment for our patients that are in knee pain. As everyone is aware, elective surgery has essentially been shut down. We have no idea when that's going to be reopening at this point. So, for me, as I was trying to decide what sort of treatment options that we have for our patients with osteoarthritis knee pain, I was like, okay, let's come up with a plan that's going to minimize the exposure to patient and staff. But then we also want to have some duration of action, right? I want a reproducible, reliable duration to hopefully allow the patient to get pain relief, be seen quickly for a 10-minute appointment for an injection, and then allow them to sort of hopefully stay out of the office for a period of time. So that's for the process of what's happening here during a pandemic. Now let's talk about post-pandemic. As we emerge from this pandemic, how are we going to treat our patients? We're going to have a huge backlog. I mean, these elective surgeries, we were barely keeping up with elective surgery for most arthroplasty surgeons in the pre-pandemic era. So how are we going to do this with all of these extra patients? So Vin Das is a close friend of mine, vice chairman of the LSU Department of Orthopedics. He's predicting it may take 2 to 3 years for us to be able to manage this backlog of elective arthroplasty patients. So what are we going to do? Well, we got to provide them pain relief, and providing someone with pain relief with a reliable, predictable 3-month course of action or duration of action, according to the FDA pivotal study, upwards of 70% of patients get pain relief out to 3 months. That's pretty good. So really, ZILRETTA falls into a really good option for treatment for me as well. So I am also a national leader in opioid sparing strategies. It's one of my great passions. One of the things that I'm most worried about with teleconferencing and this backlog of patients, our doctor's going to get a little lazy here and start prescribing opioids for these chronic conditions. And I want to emphasize, so important, the last thing you want to do is take an opioid naive patient with a chronic problem and provide them opioids, because now you've made them opioid addictive and now they have 2 problems. So a couple of things that have sort of come up as in the discussion as we've been talking about our plans within our office for treatment. One of the concerns that I hear routinely is, are we setting up our patients for a decreased immune response by doing a corticosteroid to the knee in the setting of this pandemic? And the CDC has opined on that. And they have basically stated at this point that there's no evidence for decreased immunity in the setting of this COVID-19 pandemic. So we're following along the CDC guidelines. And when patients are in pain, requiring issue, I think an intra-articular injection of corticosteroid is very reasonable. And then providing them 3 months of relief, ZILRETTA is my go-to to try and keep them out of the office for as long as possible. One of the other things, I'm going to finish up with this, is that we hear routinely about when can you do a knee replacement after an intra-articular injection of cortisone. And if you poll surgeons across the country, it's anywhere from 3 months to 6 months, but most people sort of fall into the 3-month category. And the thought process is the reason that you have a slight increased risk of infection after an intra-articular injection of cortisone is that you inoculate the joint with maybe 1 or 2 bacterium that just sort of sit there. And then they're waiting for action, you do surgery, and then infection happens. So to be clear, there are no studies on ZILRETTA at what timeline would be safe or not safe in the setting of a total knee replacement. What we do have studies which clearly demonstrate that ZILRETTA, which is triamcinolone acetonide, is out of the joint within 3 months. And we also have discrete evidence that shows that the microspheres, which is the delivering agent for this, is out of the knee within 4 months.